We have to start on time because we have some viewers on YouTube. So I will invite Dr. Aruna Chandran, chair of this session, to open the session. Thank you.
Thank you, Sandrine. Very good afternoon to everybody. So over the few weeks, we've learned a lot about policy and programs in cancer. Today, we're going to focus on what do countries really need to drive policy change in cancer through the public event series. Joining us today in this session are two experts who are wearing two different hats. Dr. Faisal Izwan Mustafa, who's joining us from Ministry of Health Malaysia, is going to talk about his perspective of what is really needed to drive policy change. Also with us today is Dr. Sharon Kapambwe from the WHO Regional Office for Africa, who's wearing her WHO hat today and speaking about her perspective from the WHO side. So without further ado, I invite Dr. Faisal Izwan Mustafa to start his presentation. Over to you, Faisal.
So thank you very much, Aruna. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, good afternoon, and good evening for those of you joining online and for those present here. So what I would like to talk about now is the title, what do countries really need to drive policy change in cancer? We have talked a lot about evidence over the last few days. What I would like to remind you is decisions are not made just based on evidence, right? Many factors come into play when it comes to decision making. Firstly, just for definitions, when we talk about health policies are just broad statement of goals, objectives, and means that create a framework for the activity itself. And when we talk about health policies, it doesn't just cover the public side, but also public and private. Remember that, at all levels. And it is not just about the health system per se, but also can cover the determinants of health. That means factors outside of health sector, but influences health. There are several models for policy making. What I would like to share with you this afternoon is the stages model. This is a very clean model. I'm not going to cover all stages of this model. What I'd like to intend to do this afternoon is just talk about the agenda setting and a bit of the policy formulation and adoption. While it may look clean cut to you right now, in reality, decision-making policy cycle is very messy. You can go from one stage to another, you can go back, you can skip. Many things can happen throughout a policy cycle, okay? Another model that I would like to share with you, now we're shifting only to agenda setting. So how do you get your issues? So each of your groups have your own agenda, right, that you will be presenting tomorrow throughout the day. So how do you push your agenda up? The Kingdom model is one model which is often used. There are many other models. Have a look at it. But I like Kingdom model for several reasons. So in the Kingdom's model, there are three streams. Okay? Each stream are independent of each other and they have their own life, as it were. And throughout the last 4 days that you've been here, and also from your online online lectures that you have had to follow, you would have tackled mostly on the problem statement stream and also on the policy stream. Okay, the problem statement is basically your situational analysis, where we are right now, what are the issues. Whereas the policy stream looks at all the various interventions, as it were, that some have been evaluated, have cost effectiveness data, some have not. But what we have not really discussed is the politics stream. This is where you need to engage strategic partners, where to persuade decision makers, and that's the debate right now, right? Like Patrick just now. How do you persuade us, for example? And don't forget, public opinion matters. What we as policymakers or as scientists or as clinicians think is important, not necessarily what the public thinks is important as well. So what we need to achieve, if you look at this model, is to achieve congruence, right? You want the streams to come together, and that window of opportunity, you can wait for it to happen by chance, or you can actually create an environment where that happens, where these three streams come together. And that window of opportunity is something, is very, how shall I say? You need all three streams to converge. Even if you can get the problem stream and the policy stream to converge, if you do not get the policy stream to converge, it will be very hard. And I'll tell you why it is very hard. Because in reality, when you talk to the government, to the Ministry of Health, or to other government agencies, firstly, you need to convince that agency it really matters to them, right? So for example, if you need Ministry of Education to be on board because part of your, like HPV vaccination, you need school to be on board, right? But if you cannot convince them, it is in their best interest, and it is very hard for you to get their buy-in. Feasibility, we have talked about that a lot. And support, public support is important. And why I say all this is because if you are Ministry of Health, or if you are the government, these are all the public health issues that we are facing right now. Okay, we're talking about cancer right now, but in the background, you have emerging and re-emerging public, communicable diseases, your NCDs, your aging population, urbanization, which is happening in a lot of countries, and climate change. And this is not an exhaustive list. Even if I say NCDs, you have all these NCDs competing in the same space, competing for the same resources. Even within the cancer, my cancer is more important than your cancer, of course. That's the background that you are competing against when it comes to agenda setting. Yeah, it's not just this. Of course, you can argue these all interrelate to one another. Yes, it does actually. But if you're talking about cancer specifically, don't forget. And some of you are doing something for the risk factor, right? Like tobacco, some bit more specific for cancer screening. But just remember, this is the space that you are competing against. So going back to the stages of the policy cycle. So agenda setting, I'm just going to talk briefly just now. I'm just going to cover briefly about policy formulation and policy adoption. Okay, so in terms of definition, policy formulation is the stage is where the policies are created or changed. So you may have an existing policy and you want to change, right? Or you may need a new policy. Don't forget, anything that you change, some people will benefit, some people will not benefit. In fact, they will lose out. And this is where social and political dimensions come in. For example, if you have a public and private sector running concurrently, a policy may be advantageous to the private sector or may be disadvantageous to the private sector, and they will not support you, public. Okay? Stakeholders, I've been told that you have done a lecture on stakeholder engagement. All right, so I hope you have properly listened to your lecture. There was online, all right? So stakeholder, I'm just going to highlight the importance about defining them and understanding how your stakeholders can be affected by a policy, either positively or negatively. And how do we get our voices heard? So the stakeholders are quite clever. Some are more better than others. Perhaps we working in government are not so good at getting our voices heard. Okay, because if you talk about people who do this job for a living, like lobbyists, this is how they do it. They build relationships. Maybe pharmaceutical industry is a good example. They are good lobbyists. The clinicians here will be familiar how your pharmaceutical industry representatives would approach you, right? How they build relationships with you, how they can set up formal discussions, roundtable discussions, right? And these are some of the ways they get their voices heard. And stakeholder analysis, I hope that was covered as well, is a technique to identify all key stakeholders and the steps as listed on the slide. What I will do next in my second part of my lecture is to see a real life application where I was involved. Easier for you to imagine what I'm saying right now. Because in the stakeholder analysis, this is one way to look at your stakeholders. This influence interest grid, where the horizontal axis is the interest of the stakeholder. The further right, the stronger the interest. The vertical axis is the influence. The higher the influence, further up, the higher the influence. Oftentimes, we only engage stakeholders who are influential and got high interest. Actually, you shouldn't just do that. You should also look at all your stakeholders, especially those who are opposed against you. An easy example for this will be for those working on the tobacco control, because there is an obvious opposition. The tobacco industry, and perhaps you have your tobacco farmers as well. All right. And perhaps even your finance ministry, in the case of Malaysia, where they look at tobacco as a possible source of income, or electronic cigarettes as a source of income. All right. So when you map these out, you will see, based on this grid, that there are several ways for you. Where do you place your stakeholder will determine how you engage them. Okay, and this slide shows you how you manage your stakeholder. Right, so now to the real life example for my second half of my lecture. I was involved with the National Strategic Plan for Cancer Control Program. This is for the year 2021 and 2025. I've included the link for the document for those of you who are interested in the actual document. Just as a background, these are all the NCD related strategic plans there is in existence in Malaysia. And I have had the opportunity to be the key person, the key driver for a lot of it, the National Strategic Plan for NCDs. And you will see where cancer sits within that overall big picture. Why so many? There are many players. Okay. Looking back, just stepping back at the NSPCCP, this is work that we initiated in 2019. And it builds upon our earlier two documents, which is the NSPCCP for the year 2016-2020, and what we call the National Cancer Control Blueprint, and NCCB 2008-2015. So the first work was done early on, 2008, and I'm building upon those work. The first step, so this bit is really much my sharing with you, because you won't find it in any textbook, okay? So the step one that we did was firstly to implement, to evaluate the implementation of NSPCCP the previous year and NCCB. What would be ideal is actually a formal third-party evaluation, right? But oftentimes in LMICs, we don't really formally evaluate our own programs. This is unfortunate, right? Because you need to learn from what worked and what didn't work, right? But oftentimes we don't, because we need, so that we know where we should prioritize. So what we did, we just did a SWOT analysis, and that I don't want to show the specific of the SWOT analysis because it's in the document itself. So whatever I'm showing you, it is available on the document itself. All right. So we did a SWOT analysis. This enables us to focus on which area we felt that we did better and we could build upon, or which are obvious gaps which we could now focus on. So that's step one. In terms of step two, we did a stakeholder mapping. And then for each of your stakeholder, we did an engagement strategy. That means you do not engage your stakeholders the same way for all of them. We did not engage the oncologists, for example, the same way as we did the academicians. So these are all the different stakeholders that we have. This is again, not the full list. I'm just giving you the broad categories of the different stakeholders involved with cancer prevention and control in Malaysia. A lot of stakeholders. There's a lot of NGOs, in fact, working in the cancer space. And each of the non-governmental organizations think their cancer is more important than everybody else's cancer. All right. So that is why you need to look at your stakeholders. And among them, you need to know who are the champions, who are the influencers. There will be one. And these are the individuals that you would like to engage more closely, keep them more involved. Okay? Not all stakeholders, you will be involving them to the same degree. Some just to keep informed, some just to really bring together, okay? Because they're one of the commentaries from the earlier development of the early documents, the NGOs, the academicians felt they were not really engaged. You know, once the publication, once the strategic plan was out, only then they were told about it, which I felt wasn't fair because they are important stakeholders, especially in Malaysia. Okay. We needed for step 3, a formation of a technical working group. Of course, you want to be inclusive. For me, it's easier to move if you're small. The bigger you are, the harder it is to move. So this is a conscious decision on my part to keep it small, because it is the ones who do, as it were, the heavy lifting, the heavy work. You don't want people who are there just to comment, right? And I'm sure you've been there in committees where you have people who are seniors, who are experts saying, you do this, you do that, you do this, you do that. And then people look around, who actually is doing all this? And it comes back down to you. So you might as well work with a group of people who are like-minded or willing to do the heavy lifting with you, okay? Step 4, this is something that have been told to you for the assignment that you'll be presenting tomorrow. Decide really early what are your objectives, and it has to be smart, you know, specific, measurable, achievable, realistic, and time-bound. Can be your specific objectives and your overarching and your overall targets. This has to be decided very early on. For us, it was quite easy to build upon what was decided earlier and to fine-tune it. Step 5, learn from other countries. Over the years, other countries have produced their own strategic plans. So look at them. Look if they have published any implementation issues, especially on published journals. And not to forget, well, I'm not, you know, learn from WHO. Well, sometimes people will comment, you know, WHO is too broad, WHO do not know local context, but there's always something to learn from WHO, from IAC, and from other related international organizations. There are a lot of strategic documents, there are a lot of guidelines that you can reference, and you can, you know, you're not starting from scratch, even if you are first time developing your own strategic plan for your country. Number 6, this is something that we had to do, prioritization. And idealist versus pragmatist. If you look at the current strategic document, it is about 175 pages long. And you know why? Because I had to accommodate all cancers. You know, you want to be inclusive. I can't exclude, you know, just because the burden is low, because there are people with those cancers, and we need to see how we can provide services for them. But one thing we did, and you know, and this wasn't easy, was to include a chapter on priority within the strategic document. As listed, you would be able to see these are the 4 things. And why we needed to do this is because resources, especially additional funding, is limited. So if you ask for example, 100 million, and you only get 2 million, you have 2 choices. Either you split the 2 million across all to be fair, or you spend the 2 million for specific things. I take the view that I would rather split it for specific things, because if you spread it out too thin, then everybody gets very little money. But you're being fair, right? Nobody can complain. Everyone's getting their money. But with that very little money, like 10,000 or 5,000 USD, for example, what can you do? Nothing much. But what if these are our priorities for example, number 2, increasing colorectal cancer screening, right? So it's not that we're depriving the breast cancer or cervical cancer program. They are still getting whatever money they're getting, but anything additional, we're pushing it for something else, right? So this is again listed within the document as a set of priority that have been agreed. Yeah, it wasn't easy. And that is why I put in what additional skill set that you would need. We talked about it also somewhat. And for me, it being an advocate and being a negotiator as well. Because if you're leading this, you need to advocate and you need to be a strong negotiator. And lastly, once you have developed your document, you need to prepare to present it, which you are doing tomorrow. Right? So seriously, it is about selling it. You have to be a salesman. A salesman do not sell stuff to you based on evidence. He may tell you, you know, the car It's very economical, but it may also tell you it looks good, it matches your persona kind of thing. You look very much, Alfred here, I'll sell him a big car, like a big pickup truck, it'll fit him. That's not evidence-based, obviously, right? But it is being a salesman. You have a product. Your product is your proposal. Okay? And why I put there a lobbyist, in fact, before you present to a formal committee, you can always lobby behind the scene, even before you go into the meeting room. You should, actually. Do not do not go inside there unprepared by not lobbying, finding out who are your champions, who are against them, who are against your idea, and finding out and preparing your counter rebuttals, as it were, because there will be people who are against certain things, and you can prepare better if you have done your lobbying work. Okay, so that will be my sharing with you in terms of the steps that I actually did in developing the NSP CCP. So my last message to you, because in this room, you are either clinicians, public health practitioners, academics, scientists. So you are my target audience right now, and this is my message to you. All right. Firstly, yes, we talk a lot about evidence, but we have to acknowledge decisions are not based solely on scientific evidence. If this was the case, I started my public health career mostly in diabetes space. And I keep telling people, if evidence is what changes people's behavior, then in a consultation room, when I'm sitting with a diabetes patient in front of me, then I just need to show the evidence coming on from Lancet or Nature. Look here, if you follow what I say, 50% reduction in your risk of complications, getting a heart attack. And if you truly believe that will change the patient's behavior, then you're really mistaken. They don't. People make irrational choices. Organizations make irrational choices, right? So first, acknowledge that. Secondly, my message to you, that window of opportunity, either you try to create them, it's not easy, I don't have an easy answer for that, but sometimes it can happen. For example, the reason we had a National Cancer Institute or even a National Heart Institute was firstly because the then Prime Minister had a heart attack in the 1980s, and later on, it was the wife of the Prime Minister. That was the window of opportunity, right? So that happened by chance, but you can actually try to create, because when you have the critical coupling, then your agenda may move forward. My third message, know and manage all your stakeholders well, not just those who are your champions, but all, especially those opposing your ideas. And lastly, I'm not asking all of you to require additional skill sets. Nowadays, it is impossible. We all work as a team. So if your strength is in the technical, you're the scientist, then you need partners who are experts. Well, basically, you need your salesman. So get your salesman, or learn to become a better salesman, for example. Okay, so this, I would say, if you work in the policy making space, additional skill sets that you need to acquire, or to get people to work with you closely who are experts in this area. And with that, I'll stop my presentation. Thank you very much.
Thank you, Dr. Faisal. I'm sure you have a lot of questions to ask him, but just hold that thought. We will keep the Q&A session for the end of this session. Now I would like to invite Dr. Sharon Kapambwe to commence her presentation. Over to you, Sharon.
Thank you so much, everyone, and thank you for the people that are joining us online. Good morning, good afternoon, good evening. So I was asked to talk from my experience from the WHO perspective of what do countries really need to drive policy change in cancer. Thank you to my colleagues who helped to share some slides and also the discussions we've had in between. So I think the first aspect that we really want to look at, and Faisal has done a great job breaking down policy formulation, policy cycle. So I'll try to make sure that I stick to what really we're doing from the WHO perspective. So this is the current status in terms of major burden marked by inequalities. So we know that diagnosis with cancer per year is 1 in 3 lifetime risk of being diagnosed with cancer in high income countries. Lifetime risk in low income countries is 1 in 6. And countries on track to reduce premature mortality from cancer by 1/3 by 2030, only 14 out of the 196. And I'm sure I'll be asked, which are those? And we look at that map and try to see what is really happening. Cancer and cardiovascular, that's 2019, cancer and cardiovascular diseases ranking as the 2 leading causes of premature death in 127 countries in 2019. Cancer may be the leading cause of premature death this century. So the other part that we come and look at when we're looking at cancer really, and that is where we're talking about what is the situation, what is obtaining, is that we just don't look at the numbers and try to think that's all we have. We also have to look at generation harm. And if you can see, that's someone in deep thought, premature deaths and impoverishment. So greater than 60% of people with cancer experience anxiety or depression, and greater than 70% of people with cancer experience financial distress or hardship. And most of you have talked about how people, not only financial hardship, but also, a lot of opportunity costs in terms of time that happens when somebody has cancer. And critical is really knowing that it's just not me who has cancer who's affected. It's also the people. And if we look at settings in most of the lower income countries, it's the people around me as well. If I have cancer, it affects my immediate family, my children's ability to progress. And there are other people in some of our cultures where we're still in an extended form. So if I'm not there, it means other children who are benefiting through me are also affected. So we find that 2.1 maternal orphans per cancer death. Cancer affects women, 2.7 million women aged between 25 and 54 years old. And greater than 30% of the people affected by cancer and caregivers experience unemployment after diagnosis. And if you've worked in the cycle of childhood cancer, you will find that it's a very unique, and you'll find that, one parent is by the bedside or both parents have to exchange, and you find that they're not going for work. Even if they're not in formal employment, they can't grow their food because the child is in hospital for most of the time. And even if it's another person, if it's a woman, it means she was the one who was selling by the roadside. That is no longer happening, and children are not going. So those are some of the generation harm, even as you're making a policy decision that needs to be looked at. And of course, there's a GDP loss of 0.5 to 2% that must be looked into. So really, that is the current global status or status of cancer that we look. I'm not going to, I think Faisal has done a remarkable job, and I don't want to take away from what he has done. And I was basically just looking at some of the guidelines we have on policy cycle or action cycle, understanding the problem. This was already talked about. Evidence-based, unbiased, impartial, and fair. So whatever evidence you have, and local context. It's very important. Local context can mean your district, your city, your nation. Your local context is where you are going to implement the policy you're making. Equity considerations. Today we heard from the students in the class who were talking about equity. Should we include boys? Should we have gender neutral? Should it just be girls? So it's the issues of equity as you are thinking of policy that must be considered. issue of stakeholder mapping and analysis has been talked about. Be transparent and inclusive, and always identification of the criteria in the local setting. Of course, this will be followed by designing of solutions, and then you design the implementations, communicate and engage. We make policy and then it's not communicated. So that also becomes a big issue. Is you have made policy, you must be able to communicate, you must be able to engage, people must be able to speak to it. Most of the policies that will be done, you find that on the ground, they really haven't been thoroughly understood. If we go, there was just a presentation even on cervical cancer screening guidelines, where an assessment was done, and you'll find that people are still screening as young as 16, in the programs, meaning that we have made guidelines, but people haven't understood, and they're still going on. They're using HIV testing, mRNA, where we're saying there's limited data. So that is because maybe it's about engagement and communication. Implement, monitor, evaluate, and adjust. Most of all, is this policy sustainable, and will it bring system change? And I move on to the WHO approach in policy direction. So really just looking at the overview of major milestones that WHO has made as far as cancer is concerned, and making sure that we're having the right policy. 2018 for cervical cancer, we know, and the Director General made a call to action for cervical cancer elimination. September, during the UN General Assembly, a side event, there was a launch of the WHO Global Initiative for Childhood Cancer. And of course, there was also looking at the pricing of cancer medicines and its impact that was undertaken. 2019 guidelines for pain management, monitoring system for cervical cancer. So you see that there has been some major milestones that the WHO has been looking on from 2018, particularly up to 2023. And these are some of the issues, even as you are making policy, that can be referred to. So one of the key things we hear about the best buys, and in May 2023, during the World Health Assemblies, which just ended, World Health Assembly 76, there was an expanded list of best buys for cancer. Remember, we had the best buys 2017, and now we have May 2023. And I've just picked on for cancer, we have best buys for physical activity, for diet, and alcohol and tobacco. I picked on extended list of best buys just for cancer. And looking at best buys, these are key things that you're going to look at as you are thinking through what policies you should make. We've talked about vaccination against HPV, 1 to 2 doses, depending on what the country has chosen, of 9 to 14-year-old girls. So that's a best buy we've looked at as WHO. And when we look at cervical cancer screening, we're looking at HPV DNA screening, which is starting at the age of 30 with regular screening every 5 to 10 years. So the country will decide, are you going to do 5, are you going to 10? And you have to look into evidence into that. For countries in sub-Saharan and other countries where you have high HIV prevalence, you're going to start screening at 25 years old. So those are parts of the issues that you're looking at cancer that you'll be looking at. For cervical cancer as well, really looking at how we're going to make sure that there's early diagnosis for various programs. So as you are looking at policy, these should be speaking to what you are talking about. For breast cancer, WHO's recommendation is early diagnosis programs, which are linked with timely diagnostic wake-up and comprehensive cancer screening. We talked about the 3 pillars the other day. We have pillar 1, which is talking about health promotion, and where we're talking about clinical breast assessment. We have pillar 2, where we're talking about timely, and we're hoping that in pillar 1, we're going to increase up to 60% of the women coming in with early cancer stages 1 to 2. And we talked about pillar 2, where we're also talking about timely diagnostics and hoping that that is done within 60 days. And finally, that we'll have multimodality type of treatment, and 80% of the women will receive that comprehensive treatment. We're talking about prevention of liver cancer through hepatitis B, immunization, childhood cancer, early diagnosis, as well. As you know, that generally childhood cancers cannot be prevented. And for people living with HIV, early detection and comprehensive treatment for cancer. So what has WHO done in terms of strategic shifts in cancer as we talk about that? And this is all trying to see how we're working in the policy framework. So WHO Integrated Cancer Program, we've already talked about the Global Initiative for Childhood Cancer, WHO Cervical Cancer Elimination Initiative, the WHO Global Breast Cancer Initiative. And these are various products that have come out. We've got normative guidance, we've got global leadership and partnerships and advocacy, and of course, having a convening partners forum at the UN. For childhood cancer, more than 60 countries are now involved at various levels. Cervical cancer, more than 20, and WHO working with IAEA and IAC are doing impacts in more than 20 countries. So we get down to what really does that, getting a sample support and process of engagement and formulate policies. So you got a very good example of Malaysia, of national cancer control policies. So I'm not going to that, you were walked through. From our side is really looking at priority stages based on WHO situation analysis. Convening partners in national policy dialogue through stakeholder map. This is a repetition of what has been done. What are we looking at the end of the day to be some of the outputs when you are formulating policy? We're looking at cancer and universal health coverage, benefit package, or investment case. And we just completed investment case for Mozambique, which was the first country that WHO has really worked with to come out with an investment case. Looking at workforce optimization or training, looking at cancer center planning, looking at new legislation and national treatment standards. This in hope that when you formulate policies will accelerate implementation. So WHO supports governments and partners for action to enable the implementation of the plan, including quality of care. Also assisting countries with mobilization of resources. And we're looking about supporting countries as they are procuring medicines or other products or technologies. And working with IAC as well, looking at strengthening the registry and information systems. Once we have a national cancer control plan, we can do that. And finally, measuring impact and driving innovation. So the impact framework, midterm reviews, common communities of practice, we have that in childhood cancer, and there are many other products that WHO has. And once that is done, we're going back to looking at the policies we've made, if they should be amended, or indeed new ones should be formed. So giving a program specific example. So we've looked at what needs for formulating policy. We've also looked at how we can accelerate implementation and how we can measure what it is that we're doing. And now we look at a program specific and we look at breast cancer. So here's just some data and you find that what's the current situation? So we look at a country with advanced stage of breast cancer. Greater than 50% people are coming in with stage 3 and stage 4. A dialogue. So you have the problem is that there's late presentation in that country. Dialogue must be had. Stakeholders are coming together and looking at this, and you're looking at, okay, so what policies are we going to make? Current stage, that is what is currently happening. So we have screening with mammography, we have early diagnosis. Remember on our best buys, we talked about early diagnosis for breast cancer, which is linked with timely treatment. And when we look at that, finally, when we come and assess what has happened, you find that if we take the screening way, we are going to use about 1 to 2 million per year, increase the number of mammographies from 3 to 50, increase the number of radiologists, 3 full-time, and pathology. And the impact, which is important, will be that 200 to 500 lives are saved. If we go the early diagnosis way, you will, you're saving 200, you're going to use 250,000 per year. Remember the other side with 1 to 2 million. And then awareness, raise awareness, palliative cancer training, referral, patient navigation. What's the impact? It's going to be 200 to 400 lives saved. So this, we have done, together with the World Bank, worked with Kenya into looking into breast. And I think if you go online, you'll find that we've worked this cost evaluation, cost analysis for Kenya as well. And you find that what has happened is then the country is given the decision that they should be able to make based on the evidence that has been presented and the data that we have. So what decisions? So government invested in early diagnosis program and cervical cancer. Potential annual saving of 50,000 plus 500 plus lives that are saved. So that is looking at policy and how you can be able to effect change with evidence and looking at the problem that you have in front of you. So when we look at this, what are the entry points for engagement as you are looking at advancing and policy making? Formulate policies, we talked about that part. So it's getting a country request or activity that a country will do. And we're looking at having political commitment to participate in WHO Cancer Initiative with the 3 cancer initiatives. And then we're looking at cancer control plans and cancer as part of universal health coverage benefit package. Access to cancer products. Those are requests that can come from the country, cancer center planning, integration, capacity building, and workforce development. So WHO will support you in immediate activation of WHO Cancer Initiative networks. So currently, if we talk from Africa, you'll find that we have 5 focus countries, and then we have a lot more countries that are actually doing some work in childhood cancer, for example. And then we had 6 countries that were looked as the first phase of cervical cancer as well. So immediate activation. We're also supporting over 16 countries in the Afro region with developing of National Cancer Control Plan. WHO tool, the cancer module for One Health tool, which will help you with costing, prioritization, impact analysis, health systems planning, and investment cases. So we're looking at making sure more countries have investment case. WHO medicine support, selection of the medicine, forecasting of medicine, pricing approaches, registration, and also to be able to look at substandard and falsified medicine surveillance. Workforce capacity building, training materials in development. And of course, we have the workforce optimization too. Finally, have I gone? Yes. So finally, addressing some of the common changes that we find as we're looking at policy and looking at how we can impact cancer change in countries. So we find that one of the biggest challenges is fragmented agenda drive by external partners. These can be partners with or without any commercial interest, and failure of Ministry of Health participation in policy formulation. Sometimes you go to a country and the country is demanding that, no, we want a consultant to be able to write for us. We'll tell them what should be there. And then they write this strategic plan for us, bring a consultant to do the guidelines. So Ministry of Health people are actually not actively sitting and working in those, in the formulation of these guidelines. And you tell that if you saw how Faisal was talking through the NCCP, you can understand that this was somebody sitting at the table and making decisions. And once those are stuck, one, you create institutional memory. Even if you're not there, somebody can pick up the phone and say, okay, Sharon, how did you choose 50 machines to be put at that place? Because you were sitting at the table and debating and giving and taking, you'll be able to say, we arrived at this decision because of A, B, C, D. So there's this reliance of saying the consultant will do for us. We'll give the consultant the former strategic plan, give them all the guidelines, and then they write out that, and then we have a strategic plan. Implementation is very low. Ownership becomes low. Be involved. It's your policy, and you should be able to do it. We support you if you say, okay, how do we cost this? That is different. How do we go about prioritizing this? That is where technical guidance can come in, but you have to sit at the table and make your decisions and argue out what comes first, what doesn't, give and take, impartial. So we need to make sure that is gone. Non-evidence-based policy formulation. So it's some call it emotional epidemiology, you know, or where, you know, you sit with experts who are working and they're like, we are going to start screening at 18 because there was a young girl who died with cervical cancer and she was only 19. So that one person, and you forget that we're talking about a public health document that has to look at all the evidence that is. So you go with these professional bodies and you're fighting it out left, right, and center to really be able to help. So sometimes people are passionate, or they have someone who was close to them and they're in a place of power and say, no, we are putting this cancer. It is because maybe they saw somebody and they want it there, but is that what is best for the country at this point? So there are those non-evidence, or people are just not interested. No, whatever it is, okay, you want us to put prostate, add it. You want us to put, no matter how many, penile cancer, yes, even penile cancer had it. And when you look at evidence, maybe there were 2 people who came with penile cancer, and we want to take all the millions, and you had, 5,000 women came in with cervical cancer, and you have your best buys that are there, that this is what we can do, and then change will be there. Inappropriate practice generalize to different health systems. So you because of something that has been going on, even if it's not, you're just like, this is what has to happen. And even not taking the context of the country, sometimes country A, country B is different. Town A, town B is different. So we have to make sure that we take care of that. Failure to implement best practice. Delays in implementation. So we've noted countries, the number of countries that are producing national cancer control, for example, guidelines are many. Implementation. We produce, we rewrite in 5 years. We produce, we rewrite in 5 years. Like Faisal was saying, we need to be able to evaluate. We need to monitor. And midterm reviews is something that we are advocating for. We need to know, where are you? You told us that 2021, 2023 will be here. Have we moved? Are we doing better? So countries should be able, and bringing in a third party, because I remember when I had left Zambia by then, and was with the WHO, and when they went around to assess, come and tell me, no. So the screening coverage is 10%. And I was upset. I said, who says it's 10%? Do you know how much work we put into it? Oh, what did you use? Of course, maybe there was a different formula, but it wasn't as high as we thought. That is because you're scaling up and going everywhere, you think that's impact. But perhaps quality was not checked. There was no one looking into that. Perhaps even the target population was wrong. Just because you're screening does not mean you're screening the right people. That is why dialogue is important. And then lack of vision of sustainability. So we say, okay, we're moving to HPV DNA, we're going to go countrywide. How are we going to look at this? Who is going to fund this? How long are they funding? How do we take? And sometimes it's not everything that government can do as well. So be able to do something that will impact, but also knowing that we have to stay and be able to address the elephant in the room by talking about sustainability. I talked about clinician bias towards high-income country practice patterns. So the clinicians come in and very heavy, and professional bodies will come on you and say, no, you're not even an expert. You can't even speak to this. I am the pathologist. You're not even a pathologist. So listen to what I'm telling you. Yes, it's good to listen, but I think it's important that the clinical bias does not overshadow, especially that is seen in high-income countries. So what are the solutions to some of these things that we've seen? WHO leadership in partner engagement, direct support to MOH to convene stakeholders, mapping of partners with recognition of the roles and responsibility of partners is key. We must map our partners and understand what are they doing and where. Utilize WHO cancer initiatives to guide agenda. So you have the three, childhood, breast, and cervical. Use them. So WHO cancer initiative must be member state led, that's the countries led, and member state owned. And this will also enable your country to have a platform for accountability and oversight. Empower WHO country offices for success so that there is early definition of needs and resources and mechanisms for routine internal coordination. So as we talk about these things, let us make sure we understand what is the problem, look at the context that you're in, and know that when you go to make these policies, it's a give and take. Be impartial, be transparent, bring everyone who matters. Sometimes we only bring stakeholders who matter to us and not the ones who matter to the country. Whether you like them or you don't like them, they have to sit on the table. Whether you think they're important or not, you have, and that's where your stakeholder analysis is very important. Whether you find them priority, high priority, sometimes whoever is bringing the money, whatever they say we bring in, but the one who's working in the community might actually be giving you information that is critical for the success of that policy that you've put in. With that said, this is the end of my presentation. Thank you.
Thank you, Sharon. Can I invite Faisal and Sharon to the stage to take a couple of questions? Can I first open the floor to the participants of the summer school? There are several questions on from the live stream on YouTube, but I'm going to open it to the floor here first. Yes.
Thank you so much to the presenters for the very excellent presentation. So my question goes to Dr. Fizzle. When you mentioned about creating a window of opportunity for problem, policy, and politics to meet, we all can't be fortunate to have a high-profile person develop a heart attack. So I was wondering if you had some recommendations for us on how to create that window of opportunity, because I have a very practical situation on hand. I'm the point person to develop the health policy framework for my state. So I missed all other challenges that you had already pointed out. So how to create this window of opportunity would really be very helpful.
Thank you for that question. I had the exact same question, actually. I was sitting next to Faisal over there, and I said, if no one's going to ask you that question, I am, because you spoke about the different streams coming together, but that's not something that happens very often. If it does, yes, excellent. But if it doesn't, how, as advocates, how do we create that window of opportunity?
So it is a hard question, firstly, but there are several things that I would say makes you better prepared. So firstly, you do not, more often you cannot predict when that window of opportunity will come. That means you need to be prepared. So that's first. So I can relate this example, a real life example, when we had a new health minister and suddenly he wanted a proposal. I could produce it almost immediately because I was working on it for many years. It wasn't going anywhere. I parked it aside, but it was ready. So that means your first stream and your second stream, your situational analysis and your policy was already ready. Okay, so being prepared is one thing. If you have an agenda, that means it only needs updating, because if you tell your boss, or give me 1 month, I need to form a committee, together, you know what will happen, right? So even the person, the minister asking will lose interest. And if you imagine, if he asks you today and by tomorrow, here, minister, I've got a full proposal for you, he will be very impressed. And that is another window of opportunity. The other thing is about, like say, it is your prime minister or head of government. It is about mapping who influences his decision as well. It doesn't have to be directly to him. Who are his key advisors? Can you access his key advisors, for example? Who does he listen to? So it doesn't have to be advisors as well. Sometimes you have formal advisors and you have informal advisors. All of us have that actually, whether you realize it or not. There are people in your office working with you who actually strongly influence the way you think. I'm mapping them out, and I'm not asking you to be pretentious, but I mean, it is important for you to have a people skill, networking, and when the opportunity comes. So another real life example, without taking too much time, with this new government, we have our first female health minister, first ever. Before this, there were only males. And I realized we also had a female education minister and a female minister of women and community. And one of the issues that we were facing is poor mental health among adolescents and children, malnutrition among children and adolescents. So, and if you look, and also sexual and reproductive health issues, violence among children. If you look at these issues, the determinants are all the same, the determinants. And if I could get these three female health ministers to work together, if I could, you know, that you need to find a win-win for them. A win, not your win, their win. So these are what we say, just, I know still very high level, very vague, but these are some of the, I would say, principles, as it were, that I hold on to keep my agenda. For the other thing, you have to be very patient. This is long term. This is like a marathon. This is not a sprint. And you know, be ready. Yeah, the initiative that I was talking about, unfortunately, that minister suddenly changed, so I have to park it again. Hopefully, there is another window of opportunity for me to bring it up again. So it's always, it is a long term, unless you have something to add to that, Chair.
I think Faizo has summarized it well. Be ready. I was talking to, I think it was Isha, that I told that, you know, always have a budget, have what you do. When the window of opportunity knocked, the World Bank had given funds for maternal health and reproductive health for Zambia. And then there was still some money that was not spent. Either, you know, the bureaucratic procedures were taking place and they were not able to implement. So they asked which other programs could they give to. So they invited cervical cancer, they invited malaria, they invited us, and they had a panel of international experts that came. And I did my presentation of red to a bit green to very green, where by then it was where I wanted to be and all that. And so the head of the delegation tells me those underserved provinces is where the World Bank is also working. Tomorrow, can you tell us in terms of everything, training, whatever needs to be done to make the map green in those places? Okay? That's a window of opportunity. Somebody has just come in and nobody had funded that. All the partners were not working in those regions. So I went to my team, I said, we're not knocking off. I'm buying lunch, I'm buying supper, everybody's here. The only thing you're doing is going to the toilet, take a break, come back, and we sit. And tomorrow morning, because we already had the figures, so we just needed to start changing and writing a new concept that everything was there. We knew how much it cost to set up a center. Or we looked, and on speed dial, where we had already done a plan for the whole country. So it was calling back the provinces. Do you still need this? Yes. Okay, fine. The next morning you go, okay, so this is where we want to go, and this is how it will be green, okay, fine, we'll get back to you. Out of all the programs that presented, I did manage to get $3 million for the program, and we made the 5 provinces green. So it's been ready. Be ready, be ready. And for politicians, yeah, that's another, it will knock you. All of a sudden, you have a first lady who's a gynecologist. Who best do I have to advocate cervical cancer for? She understands. She's seen women dying. And she's right next to the president. And this is our time to get this program where it has never been before. Because the person who's in State House is somebody who knows the problem. So those are the opportunities that you should never miss. And be able, if you don't know the first lady firsthand, find somebody and say, tell her that she shouldn't forget cervical cancer as well, as she's doing maternal health project. And once someone stands and they're speaking with knowledge of what they saw on the wards and how this can change, it just changes everything. So those are windows of opportunity you should always look out for. And I love what he says, know who surrounds the people who make the minister does not sit and know what is happening in TB to the letter. It's somebody giving him information. And who are those people that are giving him information of which project? You will know them slowly. You have an idea that, normally these people are talking and sitting, and if it's not you, that's where networking, your personality, everything comes to the forward that you need to look into and make sure you approach those people. If you don't know them, somebody else knows them who you know. So get to those and make sure your proposal gets to his table.
Thank you for
her
that.
table.
Thank you for that excellent sharing, Faisal and Sharon. We have time for perhaps one or two more questions. Anybody else has any questions for Sharon or Faisal? Oh, sure. Go ahead. Sorry.
Yeah, thank you. Policy are good, but sometimes when you have a good policy not implemented, it also become an issue. My concern is, as you have seen, how to involve or to engage stakeholders while doing a policy. When it fails, do you also recommend to do the same process so that you can make sure that things are happening as per policy?
Again, a very good question. I will repeat back what Sharon have mentioned indirectly in her presentation. That sense of ownership is very important. So yes, you may say, I like the resources to engage everyone well, but you should make the effort to try to make them at least aware of the work that you do and a policy that you're being developing, even if it's an idea, and giving them an opportunity to engage actively if they wish to. I think that will be step one in ensuring, because if you lack ownership, you won't enforce. If you have some ownership, if you made your concerns quite clear, I'm referring now to the enforcers. Let's say there is a group of people who are enforcing. They could be from a different ministry or different agency, right? So you could develop a policy and suddenly it's out there, and then you're telling them, look here, you have to enforce. Of course, they'll say no. Nobody wants extra work, okay? That's another general principle, okay? Nobody wants extra work. But if you engage them early and you know their concerns, at least you can try to see whether you can address their concern. I'm not saying that's the solution, but at least you would be able in a position to try to see, okay, let's find a win-win for you as well. Because it's not just extra work. You could gain something out of this as well that could meet your target or your deliverables, as you were, or whatever your other organization wants. And part of the involvement could be to a higher degree what I call co-creation. That means involving them with creating it as well. This one is a bit difficult because it does involve a bit more work from you if this is work initiated by you. Co-creation is much harder work, involving people earlier on to create the policies that you want to. Oftentimes, even in Malaysia, for example, if you're creating policies for the young adults, adolescent, how engaged are you with them? More often, we don't have, well, at least my country, don't have formal platforms where the young are engaged. Our MPs are hardly young, right? But you are talking about policies for the young. So then how do you expect them to enforce, right? Whereas I've been to Taiwan, and they even have parliament for the young adults. And there are platforms for young adults to be involved with the policy making processes within the public sector. So if you had that mechanism, of course you had ownership, of course easier, right? Not just older people making policies for young people and for the next generation, as it were. Enforcement is always an issue, I agree. We are still struggling with that. So if you do find a better solution, please share with us. Anything to add to that, Sharon?
I think failing. The first National Cancer Control Plan we did, we had breast, cervix, retinoblastoma, and prostate as the key 4 cancers. And that was basically because everybody said, let's put equity into perspective. So we need to tackle the children, we need to tackle something for men, women. We know that the top 2 cancers, and we were also picking cancers that we knew that either there was prevention available, or we could do something as early diagnosis. Children, we could ride on into the growth monitoring clinics and involving nurses there, so that we have some form of early diagnosis or teaching them some early warning signs. By the time we were ending 5 years, first 5 years, believe me, we didn't do much for prostate. We didn't do much for childhood cancer either. But for breasts, the most we did was to develop to just have a consensus of early diagnosis as the way to go. Was a big step, and we were able to launch that. That's what we did. Cervical cancer was shooting everywhere. They had opened, they had done whatever they did. But guess what? When we came to the second National Cancer Control Plan, WHO had come up with the WHO Childhood Cancer Initiative. And one of the key questions when they were choosing focus countries, do you have a policy that includes children? We had that strategic plan where we had said we want to look into retinoblastoma for children. And Zambia was one of the 4 countries that was chosen as a focus country. Because even though we didn't do anything about it, at least we thought about it and we put some structure to it. So there were very few countries that actually had anything to do with childhood cancer, that we stood a higher chance of being selected than the other countries. So you could fail now because no partners are coming, but like he said, don't give up, keep that what you have, because you don't know. We didn't know that in the next 5 years, there'll be a turnaround and all of a sudden there'll be this launch and they'll be asking, for childhood cancer initiative, and we'll be asked to apply by the WHO as the Ministry of Health, and we showed them what we were doing, very minimal. But now we have a lot that we have achieved in the second one, with training, with everything, with the support that we've been getting. So that's that. So not everything works. We're still pushing prostate. It's still not there. Breast has been pushed. So yes, something that you start might not work. If we had left them, would have probably forgotten about them. So making a plan is important. Where you have failed, accept and say, why have we failed? Because maybe there's no one who's interested in prostate. We ask everyone, how can you help us? Nobody's coming for, not prostate. We can help you with breast, we can cervix. Prostate, no, we don't have. But who knows? In the next 5 years, in the next 2 years, there's another move that can come. So keep the focus, local context, and what you have. If you don't achieve, analyze why, and maybe reduce your expectation as what you can do as a country.
Sharon, if we can take one last question, this is probably for you. How can IARC or WHO support capacity building? And the question is specific to Breast Cancer Research Initiative, but perhaps you can comment generally, how does WHO support capacity building in countries for specific cancer initiatives?
Okay, so support, like I noted. So these initiatives are Ministry of Health, or we say member states. So it's Malaysia, it's India. They are owned by you, and your ministers endorse to say, India would love to be part of what is happening, Nigeria, and all that. So when we get a request, and most of these initiatives, we get a request, it will go through from from the Ministry of Health, it goes to the WHO country office. You say what it is you want, and we're asking what is it that you're looking for? You're looking for technical support for what? To develop a document, to start the program, and you itemize that, and then it will go to the regional office, the 6 regional offices. If it's Africa, it comes to Afro, and we'll be able to read and look at how training for cervical cancer, some of you have been trained by WHO, either in LEAP, in VIA, and we bring people together. For breast cancer, we will be looking into trying to train, health workers in clinical breast assessment so that we can be able to move. So it's not everyone, but at least if you put in a request, we'll be able to get back to you that we can help you in this way. We can help you come up with these guidelines. So your regional office will be able to respond. And of course, we work with the headquarters as well, and then we'll be able to do that. So that is, countries have been supported in developing guidelines. Countries have been supported in orienting health workers. So different aspect of coming up with what the country is asking for, and then we look into our mandate. If we feel, for example, it's cancer registry related, we also communicate with other UN agencies. I'll pick up an email and say, Freddie, I think this country is more in need of this. How do we help them to set up a cancer registry? Freddie will get back to me. Okay, let's put in the other people. I think the last in November, we actually went as WHO, IAC, and the African Cancer Registry. We went to see Fiona in Uganda, and we went over to Kenya as well. And Fiona told us our problems on cancer registry. I think we helped somehow. And because we went, WHO went, IAC went, we met in Uganda, we went to the Vice Chancellor and looked, and they asked, what can we do? And they said maybe they need to make a committee that is looking into data management and everything, and how can you help us to make sure that everybody is at the table? So yes, so the country writes that we are having a challenge with cancer registry or data management, and we work together as a force and try to see, and then people will be following up. If we need to orient people into collecting data, then IAC will look into that. If they need retraining, then we look at how we can help countries. So be in touch with your country offices at country level and know them and talk to them. They are always in touch with what is coming up with WHO, with IAC, with IAA. We'll be able to organize the 3 UN agencies involved in cancer work together as a team, depending on what is coming. I hope that's good enough.
Yeah, thank you so much for that excellent sharing, Faisal and Sharon. We really appreciate it. I'm sure the participants here and those who joined us online benefited from that presentation. With that, I close the public event series for today. Thank you so much.